Good afternoon. Moving to case number 6. This was 21-year male who came in September 2020 with the complaints of gradually progressive bilateral diminution of vision for 8 months. He also had history of headache for 2 months. He was taken to one private hospital. He had an episode of generalized tonic-clonic seizures which lasted for few seconds. He was having post-ictal confusion and he did not recall the event. Then he was referred to JJ Hospital where the imaging studies revealed two large, well-circumscribed, hyperdense, intensely enhancing lesions arising from bilateral planum sphenoidally, and they were encasing the optic chiasma in the midline. The feature suggestive of bilateral sphenoid wing meningioma most likely was given by radiologist. Now, this was very large lesion at a difficult site, and surgeons decided to operate one site at one time. So they operated left side first because it was causing quite a small mass effect. Patient came back in June 2021. The complaints were same because right-sided lesion was still there. This was extraction enhancing mass arising from right planum sphenoidally, and it was causing a compression of optic chiasma in the midline. The feature suggestive of right-sided sphenoid wing meningioma was given by the radiologist at this time also. He was operated for right-sided sphenoid wing meningioma. One HE slide from the right-sided lesion was uploaded. May I request Dr. Rahul sir from KM Hospital to discuss this case? Sir, we have provided 6 microphotographs. Please.
Yeah, good afternoon, everyone. Sir, am I audible?
Yes, sir. Thank you.
Okay, so here we see a lot of dense inflammatory cell. Yeah, same picture. In this, we can see the dense lymphoplasmacytic cell infiltrate. There are some larger cells which appears to be histiocytes, but on this par we can see the inflammatory cells which are present, and among this there are numerous histiocytes which can be seen. Those have abundant eosinophilic cytoplasm. um, yeah, same picture is seen in this section also. uh, okay, some of the histiocytes, yeah, the same picture, the some of the histiocytes in this, they are showing features of engulfment of the inflammatory cell. So that is a feature of emperipolesis which could be seen here. Yeah, and this high power view clearly shows the engulfment of the intact cells, both lymphocytes as well as plasma cells. The perinuclear hawk can also be seen very clearly, which denotes the engulfment of the intact cell by the histiocyte. Okay, so considering the picture of dense lymphoplasmacytic cell infiltrate, as well as numerous histiocytes, which are showing features of emperipolesis, the diagnosis which we concluded was that of Rosai-Dorfman disease. Although the site is somewhat unusual, but extranodal Rosai-Dorfman disease can present in 5% of cases in the CNS location. On imaging, the diagnosis given was that of meningioma, but in cases, the Rosai-Dorfman RDD, which presents in the CNS, it also presents the same feature on radiology, that is hyperdense, and it is also intensely enhancing with contrast. So it usually mimics meningioma on radio imaging finding. In negative finding, there were no brain parenchymal tissue seen. There were no atypical lymphocytes or immature plasma cells. There were no increase in eosinophils, no fungal organisms, no necrosis was seen, no two-tone type giant cells were noted. So our diagnosis is extranodal Rosai-Dorfman disease. One thought was due to the increased number of plasma cells. did the IgG4 related disease. Although emperipolysis is not seen and no large areas of fibrosis was noted, especially storiform fibrosis, but towards the periphery of the lesion, there were few blood vessels which shows features of obliterative phlebitis. Also, the wall of the blood vessels were thickened and highly nice with perivascular fibrosis. So, yeah, so IgG4 also needs to be ruled out uh, in this case, and the final diagnosis remains as extranodal roside-Dorfman disease to be confirmed by CD68 and S100, although IgG4 needs to be ruled out. Thank you.
Any other opinion? Very well described, sir. You did my job easier. In September 2020, 21 male bilateral gradually progressive loss of vision, bilateral meningioma on radiology. Surgeons decided to operate the left-sided lesion first. We had talked regarding this with them. They told that this is a difficult site and they cannot operate both the large lesion at one setting, and they operated this left-sided lesion first. The intraoperative squash were suggestive of this neoplastic etiology. We reported this as likely neoplastic etiology. We received multiple fragmented tissue bits which showed this chronic dense inflammatory infiltrate, predominantly small lymphocytes and few plasma cells, along with few histiocytes, which were showing this phenomenon of emperipolysis as well described by sir. But this slide is old, from the September 2020, and we missed this feature at that stage. So we ended up labeling this as inflammatory myofibroblastic tumor, that is also called as inflammatory pseudotumor. Now surgeons sent paraffin blocks to Tata hospitals where they did IHC marker in addition to this histopathology. The histopathological diagnosis, the description was similar. They did IHC, predominantly small lymphocytes with few B lymphoid cells, and CD138 were marking these plasma cells. Some of them were positive for IgG. 5 to 10% were showing this IgG4 positivity. Few histiocytes marked CD163. Smooth muscle actin and ALK1 were negative. So considering this histopathology and IHC findings, it was labeled as sclerosing lymphoplasmacytic rich inflammatory lesion, which is reminiscent of inflammatory pseudotumor. The patient was sent home with the supportive treatment, and he came back in June 2021. There was this extraxial right-sided lesion, well-defined mass arising from right splanum sphenoidally, and it was compressing the optic chiasma in the midline. So the complaint of loss of vision was still there. At this stage, the radiology was again sphenoid wing meningioma and intraoperative squash were inconclusive. The right-sided lesion is operated at this stage, which we circulated the slides. It was showing this fibrocollagenous tissue along with dense lymphocytes and plasma cells, along with this and histiocytes, foci of histiocytes showing engulfment of lymphocytes and intact plasma cells, that is imperiopolysis. And although histology was typical, we ran S100, which nicely demonstrated this emperipolysis. So diagnosis of extranodal Rosai-Dorfman disease, as very well described by KM Hospital, was given at this stage. But we went back in past and we took our old slides of September 2020. Then we came to know that the slides were showing this feature also, which we missed at that stage. And we compared the slides of left side with the right side lesion. Both of them were showing this almost similar feature, and we label this as extranodal bilateral clinoidal Rosai-Dorfman disease. Why we presented this case? After exhaustive literature research, we came to know that this is a very rare case. Anyways, central nervous system extranodal Rosai-Dorfman disease is a rare disease. CNS unilateral sphenoid wing Rosai-Dortmund disease is the rarest disease. However, CNS bilateral sphenoid wing or bilateral clinoidal Rosai-Dortmund disease has never been reported in the literature, and this is the first case in the world to be reported as bilateral clinoidal extranodal Rosai-Dortmund disease. This is the uniqueness of this case. That's why we kept this case here for discussion. Apart from that, clinical and radiological finding, it mimics meningioma as reported in many studies. And although inflammatory pseudotumor and this extranodal Rosai-Dortmund disease have the same outcome and the same line of management, we missed this emperiopolis in the first setting, in the first reporting, which could have been avoided with the careful histopathological examination. Thank you so much.